I've been asked this afternoon to discuss what's new in thrombosis and myeloproliferative neoplasms. I just want to start out by saying that there's not much new, and it's very unfortunate because the intersection between coagulation medicine and the disease states that have as one of their major complications either thrombotic or hemorrhagic complications just has not been studied in an adequate manner to be able to come up with any kind of meaningful data to be able to predict who's going to have what particular type of problem when you're looking at a set of biomarkers. And so I'm going to go ahead now and discuss with you what we do know, what has been considered to be new information, but I want to indicate to you how unhelpful that new information is. And the bottom line here is that we need to be able to have better collaboration between the benign or the non-malignant hematologists who do coagulation studies as well as the clinicians who are in the trenches taking care of the patients so that we can come up with some meaningful information. But just to give you a general overview, it's amazing when you think of it that thrombosis is really one of the major causes of death in polycythemia vera and ET. And it's not just the venous thromboembolic complications, pulmonary emboli, that are associated with the mortality. It's also arterial thrombotic complications. And combined, arterial and venous thrombotic complications account for almost 50% of all disease-related mortality in the myeloproliferative neoplasm arena. If you add to that the hemorrhagic complications that are also associated with morbidity and mortality associated with this disease, it's at least another 5 to 10% of individuals who have serious enough bleeds associated with MPNs that require transfusion support. Fortunately, however, most of the patients who have arterial thrombotic complications don't die, but they are oftentimes incapacitated, which means a major difference in the quality of their lives. And hemorrhagic deaths are still somewhat unusual in the myeloproliferative neoplasms. However, you have to take a look at each one of the categories of myeloproliferative neoplasms because whereas hemorrhagic death is uncommon in ET and PV, it is more frequently a cause of death in primary myelofibrosis. But still, thrombosis is more significant. And if you take a look at other myeloproliferative disorders such as CML, we don't usually see the thrombotic or hemorrhagic complications in that kind of myeloproliferative neoplasm. So we now have a spectrum of diseases where you really have to look to see which disease you're dealing with and then create risk stratification for each one of the diseases. And that brings up the emphasis of what Carlos was just telling us, is that many of the old studies that I'm going to illustrate, which were the basis of the risk stratification models, probably had a large number of misdiagnosed individuals in those categories of patients, so that ET patients were not ET, PV patients were not PV, and therefore the ability to stratify still remains somewhat of an issue. So when you take a look at the issue of morbidity and mortality in MPNs, it's very interesting that only 30% of the thrombotic complications in MPNs are on the venous side. So essentially, a lot of us have the impression that we should be doing everything we can to prevent venous thrombotic complications when the majority of the vascular events in the MPNs are actually arterial. On the other hand, when you have a venous thromboembolic complication, that does forebode a worse prognosis in those individuals who have venous thromboembolic abnormalities. If you take a look at the prevalence at the time of diagnosis of vascular events, they're essentially the same. There's really no difference. Maybe there's a little increase in the polycythemia vera group, but again, these are cumulative data over many studies, and so the actual definition of their disease may not have been accurate. If you take a look at the incidence after the diagnosis has been made, you can appreciate that the polycythemia vera patients are at much greater risk of developing thrombotic complications than are the other two categories of myeloproliferative malignancies. And as you can see, the incidence is up to 2% per year in the polycythemia study, in the polycythemia cohort. The other issue is that you can't separate out the venous thrombotic complications and the arterial complications because they can occur separately or they can occur concurrently. They're really unpredictable in any one individual. Many asymptomatic patients may have platelet dysfunction, and the question is whether or not the presence of platelet dysfunction in platelet aggregation studies, for instance, or the increased hypercoagulability markers that are present in these myeloproliferative neoplasm patients actually mean anything prospectively to the patient. And I'll show some of the conundrum that we have in trying to figure this out in a few minutes. We also don't really understand what the effect of phlebotomy or cytoreduction is on most of these patients' biomarkers for hypercoagulability or for platelet function. Are we actually phlebotomizing patients to a point that the rigidity of the red cell actually increases the likelihood of thrombosis in some of the patients who have polycythemia vera? This has never been studied. Do we know whether or not the antiplatelet therapy that is part of the treatment modalities in most of these patients with high platelet counts, do we really know what we're doing with these patients? Because in all of the studies that have been performed, the bottom line is, yes, there is a decrease in the thrombotic incidence of complications. However, that risk per incidence never gets down close to zero. So there's got to be other issues that we have to be looking at in order to understand what the pathophysiology is in the myeloproliferative neoplasm patient. Now, there are some characteristics of patients who have thrombotic complications in the myeloproliferative neoplasms, and that is there is more likely to be a myeloproliferative neoplasm associated with the presence of blood clots that are in unusual places. If you have a patient who has splanchnic thrombosis or cerebral sinus thrombosis, you should be looking for something perhaps in the JAK2 positive realm in addition to thrombophilia abnormalities. The prevalence of abdominal thrombosis is quite high in patients who have myeloproliferative neoplasms, and I'll show you some more data in a few minutes. And I think it's incumbent upon us as hematologists that if you're called upon to take a look at an individual who has splanchnic venous thrombosis, you should be looking for an underlying myeloproliferative neoplasm. Most of these splanchnic and bizarre and unusual position clots are JAK2 positive. And there is a correlation between the allele burden of JAK2 positivity versus JAK2 negative individuals. It appears in most studies now that CALR mutations actually carry a lower incidence of thrombotic risk than JAK2 and c-MPL mutated individuals. And as you can see on this next slide, about 40% of all abdominal or splanchnic venous thromboembolic complications are due to myeloproliferative neoplasms. And so if you take a population of patients who have Budd-Chiari syndrome or portal vein thrombosis, you can see that 40% of them have underlying myeloproliferative neoplasms. I think this is really a very important issue for us not to forget when we're taking care of patients. And now there's actually emerging a subcategory of Budd-Chiari or portal vein thrombosis that just has isolated JAK2 positivity, but yet has not, with their bone marrows, begun to look quite like myeloproliferative neoplasms. The marrows look quite benign, and I think we're going to need more work to be able to follow these patients longitudinally to see what they're actually going to evolve into. The interesting thing, though, is that despite the fact that JAK2 sort of suggests upregulation of various cell line activities, the JAK2 exon 12 mutations have not been associated with an increased incidence of thrombotic complications versus the other JAK2 mutations. So when you begin to put a list together of risk factors for venous thromboembolic disease in the myeloproliferative neoplasms, you can separate these into the disease-related risk factors or the host-related risk factors. There's no question that an individual who has a hereditary thrombophilia is going to be at greater risk for developing a clot in addition to his background incidence that would be associated with the thrombophilia alone if he also has a myeloproliferative neoplasm. But here you have now a menu of risk factors which may or may not be important. And yet when you take a look at the literature, there's a lot more emphasis, as you know, on things such as leukocytosis being a very important risk factor, or circulating microparticles being a much greater risk factor for the development of venous thromboembolic complications. Now, in this blood paper, which is now 6 years old, this is sort of based on follow-up of ET patients, taking a look at these risk factors and how they actually correlate with either venous thrombotic complications or arterial thrombotic complications. And you'll see that most of these risk factors that I just showed you have been traditionally listed as venous thromboembolic complications. When you begin to tease this out in your various populations, it appears that they're more likely markers for arterial events rather than venous events. And so I think that we really have to be much more careful about what we're looking for, how we're beginning to treat these patients with either antiplatelet agents or anticoagulant agents, and what is it that we're going to achieve. And the kinds of studies that need to be done now are going to have to be done in a different manner than what we've done using retrospective data, frozen samples, or whatever it is that we've been doing. And when you take a look at the polycythemia vera group, again, taking a look at multivariate analyses, you'll see that there's really very little that correlates with the development of arterial or venous thrombotic conditions, other than the fact that the patients are over 60 years of age and they have historically had either a venous thrombotic event or an arterial event. None of the other risk factors is as important as what the patients had in their medical history to begin with. So when we begin to risk stratify for all of these thrombotic complications, and when we risk stratify so that we approach the patients in a way that we try to prophylax against the development of these thrombotic complications, what is it that we need to be aware of? Well, the literature and the experience tells us that contrary to popular opinion, there's no correlation between blood platelet counts and thromboembolic events, either on the arterial side or the venous side. Now, everyone sort of has a psychological barrier of saying if you have over 1 million platelets, this patient is going to have a higher risk of having some kind of a thrombotic complication. But when you take a look at all the patients together, that doesn't really hold true. If the patient's over 60, yes, but not necessarily the younger female who presents with 1 million platelets in ET. Of course, you try to risk reduce those individuals as far as trying to remove other thrombotic etiologies such as oral contraceptives, etc. When you take a look at cardiovascular risk factors, it appears that leukocytosis, JAK2 positivity, will predict arterial events but not venous events. CALR in ET lowers the risk of all thrombotic complications, and mutated JAK2 and CMIPL mutations increase the risk of cardiovascular risk events. Thrombophilic factors obviously increase the risk overall in both ET and PV. And a history, again, of an arterial or a venous event does not, or the history of an arterial event does not predict an increased incidence of venous events, which I think is somewhat counterintuitive. And counterintuitive also is the fact that if you put aspirin on these patients, that you can reduce venous thromboembolic events. It doesn't really make sense in the routine population of thrombotic patients. We don't usually put them on aspirin to reduce venous events, except maybe in the most recent Jupiter and the Warphasa studies that show that individuals over a long period of time on aspirin may have a less recurrence rate of venous thromboembolic recurrences. The other issue that we don't really understand completely is that ruxolitinib appears to be able to lower all thrombotic events versus best available treatment. And we don't really understand how that's accomplished. Is it because we're reducing white counts and platelet counts? Is it because we're decreasing inflammation? This appears to be certainly relevant in polycythemia vera, and I suspect it will also be relevant in ET, but we've got more data to collect. Also, these thrombotic events apply to pregnant women, and it's very important to realize that women with myeloproliferative neoplasms have a higher risk of first trimester miscarriages, which is very similar to what we see in thrombotic complications. And these women would probably benefit from being on low molecular weight heparin with aspirin or the use of pegylated interferon, and frequently, as they come to term and they get ready to deliver, we'll do elective plateletpheresis on them in order to get them through the delivery process without having stroke and venous thrombotic complications in the mother, as well as endangering the health of the placenta and the baby. So when we take a look at thrombosis risk stratification, all of you are familiar with what the literature has told us. High risk, age over 60, history of thrombosis. Low risk, absence of both factors in PV. And in ET, we have a little bit more discrimination to go from very low risk to high risk, dependent on age, JAK2 and CMIPL mutations or not mutations, and also histories of thrombotic complications. I'm going to skip this in the interest of time. But how do you put all of this together? So here you have JAK2 mutations. The JAK2 mutations upregulate cell activation in all cell lines. In actuality, it appears that the most important interactions are between platelets that are activated and leukocytes that are activated, and that they form complexes. They form these heterotypic complexes, and that when these complexes actually come together on the surface of the endothelium, that they actually can also activate the endothelial cell to become more thrombotic. So you'll see that there's a decrease in thrombomodulin production by the endothelium cell. You'll see that there's an increase in the synthesis of p-selectin, which is an adherence molecule that allows the interaction of the platelet with the white cell to come together with a von Willebrand factor protein tether on the endothelial surface. And therefore, you see that by activating the elements of the platelets and the white cells, and then also activating the red cell or changing the red cell, what we call the flip of the phospholipid template on the red cell surface, we actually then create a possible hypercoagulable state. How do we know that this is the case? These are some studies that have been in the recent literature, taking a look at how thrombin generation is increased when you increase the platelet expression of tissue factor and p-selectin. So tissue factor, if you're not familiar with that material, is a material which turns on the extrinsic pathway of coagulation. And we know that in many hypercoagulability states, particularly in neoplasms, that there is a large amount of tissue factor that's generated, and that tissue factor then will activate coagulation through both the extrinsic pathway and the intrinsic pathway. So how do you increase thrombin generation? Well, you have to have a source of tissue factor. What is that source of tissue factor? Well, the tissue factor can be increased by the presence of mononuclear cells that are fragmenting. They're tissue factor rich. The endothelial cells are tissue factor rich. Malignant cells are tissue factor rich. So if you take tissue factor and you mix it with the platelets from an individual with a myeloproliferative neoplasm, as you can see in the left-hand graph, the amount of thrombin which is generated is exaggerated over the normal individual. And on the right side is in the absence of tissue factor, where you can also appreciate that even in the absence of tissue factor, the platelets from myeloproliferative patients are also activated. And one of the interesting things on the bottom left-hand graph, you can see that there's also a correlation between JAK2 burden. So the more JAK2 burden that's present, the more tissue factor will be generated by these activated platelets. Similarly, there's this concept of microparticles. Now, microparticles, as I said, are shed from activated platelets or mononuclear cells or by the endothelium. In this particular study, platelet-derived microparticles were isolated and then added to plasma from patients, and then the attempt was to see how much thrombin would be generated with the presence of normal platelets and microparticles from individuals who have myeloproliferative disorders. Again, you can see that there is an increase in the amount of thrombin generation. There's a decrease in the lag time to be able to reach the peak amount of thrombin generation. And also, you'll see that there's a JAK2 allele burden associated with the amount of thrombin that's being generated. This is, I'm sure, too difficult to see from the back, but I think that what's happened is that Barbui and Anafalanga, Tiziano Barbui and Anafalanga from Italy, have put together a list of risk factors that are in this particular table correlated to JAK2 negative and JAK2 positive. So all of the risk factors that are associated with thrombosis are all upregulated in the presence of JAK2 mutations. Now, on the other side of the equation is the hemorrhagic complications that patients get with increased platelet counts, particularly in ET. And that is the acquired von Willebrand disease that these patients are susceptible to. This happens to be a research interest of mine. And so we've taken a look through the years at what it is that causes the large molecular weight multimers of von Willebrand factor to be absorbed to the platelet. And what is the difference between the individual who has thrombocytosis on a reactive context versus those individuals who have essential thrombocythemia with their large number of platelets? So taking a look at a broad spectrum of patients many years ago, it was determined that in actuality, platelets from reactive thrombocytosis also absorbs out the high molecular weight multimers of von Willebrand factor, the same way that ET platelets can absorb out the high molecular weight multimers of von Willebrand factor. So why is it that the reactive thrombocytosis patients don't bleed? Is because von Willebrand factor protein is an acute phase reactant. And when you have reactive thrombocytosis, not only are you increasing your number of platelets, but your acute phase reactants are also increasing. So essentially, there's much more von Willebrand factor circulating in reactive thrombocytosis so that you never ever get to a very low level of von Willebrand factor activity versus what you see in ET, where the high molecular weight multimers are sucked out of the circulation and you have defective von Willebrand factor molecules that are being circulated without having the a large amount of recovery of von Willebrand factor synthesis by the megakaryocyte. And so that is the reason why there's bleeding in ET, but not bleeding in reactive thrombocytosis. So in summary then, what are some of the implications for clinical care in the thrombosis and thrombotic and hemorrhagic context of myeloproliferative neoplasms? Well, we know that the main risk for all clotting complications in the MPNs are being over 60 and having a history of some kind of prior thrombotic complication and being JAK2 positive. We also know that individuals who are JAK2 positive, particularly in the ET phase cohort, will benefit from prophylactic aspirin. But increased bleeding risks are associated with the use of too much aspirin in these individuals, and sometimes you have to defer the use of aspirin if you run your baseline von Willebrand activity levels and note that the patient may have less than 30% activity of ristocetin cofactor. Those individuals will bleed if you put them on aspirin. One issue that's not been resolved yet, and I think is a very important one, is whether or not you can use the direct oral anticoagulants that are currently targeted against either factor 2A or 10A, drugs such as Pradaxa, all of the anti-10As. There are now 4 anti-10As on the market in the United States. These anti-10As are frequently metabolized by the liver, and in fact the enzyme pathway, the metabolic pathway, which is dependent upon metabolizing these DOACs, is the same pathway that ruxolitinib has to use. And so we don't even know if there's drug-drug interactions. What does this mean to the efficacy or the adverse events associated with ruxolitinib or the anticoagulation spectrum of these DOACs? No studies have been done. I think these absolutely need to be done. Also, we haven't looked at any of the very powerful new antiplatelet agents that are now on the market. These thienepyridines, particularly ticagrelor and pasigrel, which have been so remarkable in the prevention of rethrombosis in coronary artery thrombotic disease, we have not used in any of the myeloproliferative neoplasms in any meaningful way. I think we really need to figure this out. And then finally, how do you prioritize the thrombotic biomarkers, and how do we use them to individualize treatment? Essentially, when you take a look at tissue factor or any of the biomarkers that are being used, D-dimers, whatever you want to use, P-selectin, the large amount of variability across the population makes the use of these markers really nonsensical, not really valuable to obtain, and non-predictable for the individual who actually has these markers measured. So we have a lot to learn in the coagulation area of myeloproliferative neoplasms, and I'm hoping that maybe next year, if you come back to this conference again, you'll see some progress being made and hopefully some clinical studies that are being drafted to try to answer some of these important clinical questions. Thank you very much for your attention.